Hi everyone, this is the third video of my series on practical approach to interpretation of arterial blood gas analysis reports. And in this video, I've decided to give you an algorithm, a sure success algorithm, which can be followed to identify a probable cause of metabolic acidosis. And to break it down, objectives of this video are to tell you about anion gap in terms of what is anion gap, when to use anion gap, how to use anion gap. And I'll also be telling you about the various types of renal tubular acidosis. And wait and watch till the end of this video, because that is when I'm going to tell you about the biochemical basis of nephrocalcinosis in classical or distal renal tubular acidosis. And yes, don't forget to subscribe to my channel and to click the bell icon to get notifications whenever I upload clinical biochemistry based videos. And without further delay, let's quickly begin this discussion. And let's begin the discussion by having a look at this actual arterial blood gas analysis report which we got in our laboratory. And the question that is given to you is, interpret the following ABG report and identify a probable cause. And you're also given 4 choices of causes. One is ketoacidosis, then it's vomiting, diarrhea, and renal tubular acidosis. Irrespective of the choices of causes you have in your mind, to interpret any ABG report, step number 1 will be to identify the primary acid-base disorder. And to identify the primary acid-base disorder, we should look at pH. Normal pH being 7.36 to 7.44. Here the pH is low, so we know it's a case of acidosis. To find out whether there is respiratory acidosis or metabolic acidosis, we know we should look at PCO2. We know normal PCO2 is 36 to 44 millimeters of mercury, and here the value is just 27.1, so there is a drop in PCO2, and this is also accompanied by hypoxia. So whenever you find the combination of hypoxia and hypocarbia, it means the hypoxia has stimulated the respiratory center. The person has washed away carbon dioxide. That is why hypocarbia. And if the question in your mind is, I have learnt that hypercarbia is the most potent stimulus for respiratory center. Yes, what you have learnt is right. But hypoxia can also stimulate respiratory center when the partial pressure of oxygen falls below 60 millimeter of mercury from the normal 95 millimeters of mercury. So this means at one point of time, this person must have suffered from a hypoxia of value less than 60 millimeter of mercury. That should have stimulated the respiratory center. That should have increased the partial pressure of oxygen from less than 60 to 68, but at the expense of washing away carbon dioxide. That is why there is hypocarbia. And this combination of hypoxia and hypocarbia is observed only when there is a diffusion defect in the airway. Because whenever there is a diffusion defect in the airway, we know carbon dioxide diffusion is perfect. So carbon dioxide easily diffuses across the membrane, goes out. So there is no hypercarbia. But oxygen diffusion is not that easy. So oxygen finds it difficult to get into circulation. So it causes hypoxia first. And this hypoxia stimulates respiratory center. The person washes away carbon dioxide. That is why hypocarbia. So low oxygen, low carbon dioxide means it's a diffusion defect in the airway. So for sure this person suffers from a diffusion defect in the airway. But can that be a justification for acidosis? Can that be an explanation for acidosis that is observed here? No. Hypercarbia causes acidosis, hypocarbia causes alkalosis. So this is not an explanation for acidosis. So can bicarbonate value abnormality be a cause of acidosis? Let's have a look at bicarbonate value. So we know the normal bicarbonate value is 21 to 27 millimoles per liter. Here the value is low. So there is a reduction in the buffer concentration that has caused acidosis, which means it's a case of metabolic acidosis. So we are done with step number 1 of this algorithm. We have identified the primary acid-base disorder. And after identifying the primary acid-base disorder, can we try to exclude one of these 4 choices? Yes, we can exclude vomiting. Because in the first video of the series, I told you that vomiting causes metabolic alkalosis. And if you have not watched my first video, attach the link to the video number 1 in the description box below. So check that video to understand why vomiting causes metabolic alkalosis. So based on that, we have excluded choice B. And before we start excluding choice A, C and D, let's see what would be step number 2 in the case of metabolic acidosis. It is calculation of anion gap. So the one point which I would like to stress here is you're going to calculate anion gap only when it's a case of metabolic acidosis. Do not even look at anion gap. Do not interpret the anion gap if it's a case of metabolic alkalosis or respiratory acidosis or respiratory alkalosis. Now that it's a case of metabolic acidosis, I'm going to calculate anion gap, but before that I would like to tell you the basis of anion gap. So what is the basis of anion gap? In any physiological solution, sum of cation would be equal to sum of anion. And in your blood, what are the cations? Sodium we know is the major cation, and apart from that I'm going to consider the remaining cations as unmeasured cations. And if you're asking me why haven't they included potassium in this calculation, I consider that when compared to a concentration of 135 to 145 of sodium, 3.5 to 5 of potassium can be considered negligible. Okay, that is why most calculations for anion gap, they don't include potassium values. So sodium plus unmeasured cation is equal to, what are the anions of our blood? Chloride is an anion, bicarbonate is an anion, plus unmeasured anions. Now what is anion gap? Anion gap is defined as a difference between unmeasured anion and unmeasured cation. So can we try to rearrange this? Unmeasured anion minus unmeasured cation would be equal to sodium minus within brackets chloride and bicarbonate. So this is the formula for anion gap. So definition for anion gap is a difference between unmeasured anion and unmeasured cation. Formula for anion gap is sodium minus within brackets chloride and bicarbonate. Now what are we going to use this formula for? To identify causes of metabolic acidosis, because metabolic acidosis is nothing but a reduction in pH that is caused by a reduction in bicarbonate. So this is possible, or this can be caused by two categories of causes. One is increased utilization of bicarbonate, the other one is loss of bicarbonate. So when will there be utilization of bicarbonate? Whenever any abnormal acid gets generated. Yeah, whatever may be the acid that gets generated, we are going to represent it as Ha. That would react with bicarbonate to form H2CO3 and A minus. So in this case, what has happened? The acid has utilized bicarbonate. That would reduce bicarbonate concentration and that would cause metabolic acidosis. So this is one category of causes. And in this category of causes, do you see that simultaneously an unmeasured anion is getting generated? And we know that the definition of anion gap is a difference between unmeasured anion and unmeasured cation. Because in this category of causes, unmeasured anion concentration always increases, anion gap will be elevated. So if you find a case of increased anion gap metabolic acidosis, it's a clue that is given to you that this metabolic acidosis is caused by the production of an abnormal acid. And as I told you in the first video, the abnormal acid can be lactic acid, yeah, it can be keto acid, it can be a product of metabolism of any alcohol like methanol or ethanol or ethylene glycol. So that is about increased anion gap metabolic acidosis. Now what happens when metabolic acidosis is caused by a loss of bicarbonate? Bicarbonate can be lost either through GIT or through kidney. Example for GI loss of bicarbonate is diarrhea. Because what happens in diarrhea, in diarrhea mucus gets lost, and mucus is rich in bicarbonate. So through that route bicarbonate is getting lost, that causes metabolic acidosis. So vomiting causes metabolic alkalosis, diarrhea causes metabolic acidosis. Now example for renal loss of bicarbonate would be renal tubular acidosis. Yeah, example is proximal renal tubular acidosis. We know that the main function of proximal convoluted tubule is to reclaim every bicarbonate that is getting filtered by the glomerulus. So if proximal convoluted tubule is incapable of reclaiming bicarbonate, all those bicarbonate will be lost through urine. So plasma bicarbonate concentration decreases and that causes metabolic acidosis. So loss of bicarbonate can be either through GIT or through kidney. Now, whatever may be the route of loss of bicarbonate, the loss of bicarbonate will be compensated by a gain in chloride. So, in both these forms of loss of bicarbonate, chloride concentration increases. And that is why this form of metabolic acidosis is otherwise called as hyperchloremic metabolic acidosis. So if somebody tells you that it's a form of hyperchloremic metabolic acidosis, or if in an ABG chart you have identified that it's a case of metabolic acidosis, and then you observe that the chloride concentration is increased, it's a clue that is given to you that this metabolic acidosis is caused by a loss of bicarbonate either through GIT or through kidney. And in this case, what happens to anion gap? We know anion gap formula is sodium minus within brackets chloride and bicarbonate. And in this form of metabolic acidosis, the decrease in bicarbonate is compensated by an increase in chloride. So both these changes get cancelled. So anion gap will be normal. So normal anion gap metabolic acidosis and hyperchloremic metabolic acidosis are synonymous, and both mean the metabolic acidosis is caused by loss of bicarbonate either through GIT or through kidney. Now to find out whether it's a GI loss of bicarbonate or renal loss of bicarbonate, you will have to know the basics of renal tubular acidosis. So let me give you an outline of the various types of renal tubular acidosis. I am going to begin with type 1 renal tubular acidosis or distal renal tubular acidosis discussion. So the defect in type 1 or distal renal tubular acidosis is that of a K plus H plus antiporter. Yeah, the defect is with a transporter. What is it? It is basically a K plus H plus antiporter which is present on the apical side of intercalated cells of late DCT and collecting duct cells. And what is the function of this transporter as shown in this picture? The function of this transporter is to cause H plus secretion into the tubular fluid and to cause reclamation of potassium. And please remember, this is the major transporter through which most of the H plus gets secreted into urine. This is mainly responsible for acidification of urine. So when there is a defect of this transporter, because H plus is not getting secreted into urine, H plus will accumulate in circulation. That causes metabolic acidosis. And in spite of there being metabolic acidosis, because urinary acidification is not happening, urinary pH in this condition cannot fall below 5.3. Do you understand this disproportionate change? In spite of there being systemic acidosis and distal renal tubular acidosis, urinary pH cannot fall below 5.3 because the primary defect is with K plus H plus antiporter. Okay, and also because there is a defect in the reclamation of potassium, potassium concentration falls. So summary is, you find a normal anion gap metabolic acidosis because there is no H plus secretion into the urine. And disproportionately urinary pH will be more than 5.3, and you will find hypokalemia. So this hypokalemia is a classical feature of renal tubular acidosis, because in every other form of acidosis what you expect is hyperkalemia, because you know cell is a buffer. So when there is acidosis, the cell will try to take in H plus and reciprocally it gives out K plus. So in most of the forms of acidosis you find hyperkalemia, but only in type 1 and type 2 renal tubular acidosis you are going to find hypokalemia. Yeah, so if you look at potassium concentration, you will be able to differentiate whether it's a GI loss of bicarbonate or renal loss of bicarbonate. Do you understand this? Because in GI loss of bicarbonate, in diarrhea, what you are going to observe is hyperkalemia, whereas in renal tubular acidosis, what you are going to observe is hypokalemia. Now coming on to an interesting aspect of distal renal tubular acidosis, which is nephrocalcinosis. Yeah, Staghorn calculus is quite common in distal renal tubular acidosis or classical renal tubular acidosis because of all these three causes. Number 1, systemic acidosis. Number 2, urinary pH is alkalotic. Number 3 is hypokalemia. Reason is, whenever there is acidosis in the blood, it causes erosion of the bone. Yeah, so bone starts losing calcium. So what we observe is hypercalcemia or increase in calcium concentration in the blood, and that gets filtered in through the glomeruli. So there is hypercalciuria. Now this cannot be the only cause of nephrocalcinosis. In that case, every form of metabolic acidosis should have presented with nephrocalcinosis. So there is something additionally happening in the case of classical or distal renal tubular acidosis, and that is the defect of K plus H plus antiporter. So the primary function of H plus antiporter is to cause H plus secretion or acid secretion into the tubular fluid. And one of the acids that is being secreted by this antiporter is citric acid. And that citric acid secretion is affected. So there is hypocitrate urea. In the urine, citrate concentration is low. Please remember, calcium citrate is soluble. Yeah, calcium citrate is soluble, whereas calcium oxalate and calcium phosphate are insoluble. So until there is citrate that is found in the forming urine, yeah, it avoids stone formation. But in this case, citrate is not getting secreted into the urine. So there is hypocitrate urea. And that is why instead of calcium citrate formation, it forms calcium oxalate and calcium phosphate gets deposited as renal stones. And another reason for hypocitrate urea in this condition is there is a defect of the transporter only in the apical side. So intracellularly H plus concentration is high in this condition, and this high H plus within the cell stimulates citric acid cycle. So citrate gets utilized within the cell and citrate is not getting into the urine. Another reason for hypocitrate urea. And hypokalemia also increases citrate utilization within the cell. So ultimately there are two things that has happened here. One is hypercalciuria, increased calcium that is found in the urine. The other one is hypocitrate urea. So the high calcium that is found in urine would form complexes with oxalate and phosphate, forming calcium oxalate and calcium phosphate stones. That is why there is nephrocalcinosis in distal renal tubular acidosis. Now what about type 2 or proximal renal tubular acidosis? In type 2 renal tubular acidosis or proximal renal tubular acidosis, the defect is with bicarbonate reclamation. So as I told you when we started the discussion, we filter all bicarbonate that is present in the circulation into the glomerular filtrate, but you cannot afford to miss all bicarbonate in urine. So what we do is we reclaim all these bicarbonate in the proximal convoluted tubule. So this is done by sodium bicarbonate co-transporters. So whenever there is a defect of that sodium bicarbonate co-transporter in the proximal convoluted tubule, bicarbonate gets lost in urine. That causes metabolic acidosis. So in this case, sodium is not getting reabsorbed in the proximal convoluted tubule. So it goes through all these tubules. When it comes through the ascending limb of loop of Henle, the excess sodium will be reabsorbed by sodium potassium 2 chloride co-transporters. So excess chloride gets reabsorbed into circulation. That is why it is going to present as hyperchloremic metabolic acidosis. And this hyperchloremia is the explanation for normal anion gap. Okay, and additionally there is hypokalemia because the excess sodium reaches the distal convoluted tubule. And in distal convoluted tubule, what we do is we reabsorb sodium, reciprocally we secrete K plus. Okay, so when sodium is not getting reabsorbed in proximal convoluted tubule, sodium is getting reabsorbed in the ascending limb along with chloride. That is why there is hyperchloremia. Sodium is getting absorbed in the distal convoluted tubule and reciprocally potassium is getting secreted. That is why there is hypokalemia. So do you observe that type 1 and type 2 renal tubular acidosis are similar so far? Yeah, both present with normal anion gap metabolic acidosis, both present with hypokalemia. So how are we going to differentiate these two conditions? We can differentiate these two conditions by estimating urinary pH. As I told you, in distal renal tubular acidosis, the main reason for acidification of urine is defective. So disproportionate to systemic acidosis, urinary pH does not fall below 5.3 in the case of distal renal tubular acidosis. But in proximal renal tubular acidosis, it's a defect of only bicarbonate reclamation. So acidification of urine happens normally. So urinary pH falls below 5.3. And because it is not an alkalotic urine, you don't find nephrocalcinosis in this condition. So we can differentiate type 1 and type 2 based on urinary pH. Otherwise, they are almost similar. And if you are asking me about type 4 renal tubular acidosis, we know it is aldosterone resistance or hypoaldosteronism. And in this condition, we find again normal anion gap metabolic acidosis with hyperkalemia. So if the question is which renal tubular acidosis presents with hyperkalemia, your answer should be type 4 renal tubular acidosis. So let me summarize the algorithm. After you find out that the primary acid-base disorder is metabolic acidosis, the next step would be to calculate anion gap. And if the anion gap is high, it means the acidosis is caused by the production of an abnormal acid. So you should find out a cause for the abnormal acid production. The abnormal acid that is produced can be lactic acid, it can be keto acid, or it can be a metabolite of any alcohol. Okay, whereas if anion gap is normal, it means this metabolic acidosis is caused by the loss of bicarbonate. And bicarbonate can be lost either through GIT or through kidney. And to find out whether it's a GI loss of bicarbonate or a renal loss of bicarbonate, you can just look at the potassium value. Yeah, if potassium value happens to be high, it's mostly diarrhea. It can also be type 4 renal tubular acidosis. Hyperkalemia with normal anion gap metabolic acidosis can be either diarrhea or type 4 renal tubular acidosis. Now, normal anion gap metabolic acidosis, normal anion gap metabolic acidosis with hypokalemia can be two causes. One is type 1 renal tubular acidosis, the other one is type 2 renal tubular acidosis. To differentiate type 1 and type 2, you can check urinary pH. If urinary pH is more than 5.3, it is type 1 renal tubular acidosis. If it's less than 5.3, it is type 2 renal tubular acidosis. Yeah, so this is the algorithm that you can follow to find out the probable cause of metabolic acidosis. Now let's solve this question. We have already found out that it's an acidotic condition and that it is a metabolic acidosis. So what would be the next step? To calculate anion gap. And what is the formula for anion gap? I said it is sodium minus within brackets chloride and bicarbonate. And what's the sodium value that is provided here? 132. Minus within bracket chloride and bicarbonate. So 109 plus 14.5. So it is 132 minus 123.5, which is 8.5. And what is a normal anion gap? If you have not included potassium in the calculation, normal anion gap is 12 plus or minus 4. So it is between 8 and 16, which is the normal value. Here the value is 8.5. So it's a case of normal anion gap metabolic acidosis, which means it's caused by loss of bicarbonate either through GIT or through kidney. And the moment you have identified that's a form of normal anion gap metabolic acidosis, which of these causes can you exclude? We have already excluded vomiting because vomiting causes metabolic alkalosis. Because it's normal anion gap metabolic acidosis, I am going to exclude ketoacidosis because ketoacidosis presents as high anion gap metabolic acidosis. And then because there is potassium, which is low, I said diarrhea presents as hyperkalemia. So I have excluded diarrhea. So what is it? It is renal tubular acidosis. And look at calcium value. Calcium value is low. Ionized calcium value is low, which means what has happened? Calcium has gotten excreted in the urine, probably causing nephrocalcinosis. That is why calcium value is low. So hypokalemia, hypocalcemia. So it is probably type 1 renal tubular acidosis or distal renal tubular acidosis. This is how you can arrive at a diagnosis if it's a form of metabolic acidosis. I'm sure you would have enjoyed it. Yeah, so click the bell icon to get notifications whenever I upload such clinical biochemistry based videos. Thank you.